Thanks for this title, Chris. I feel slightly fraudulent offering you this advice. I'm not a hero and don't pretend to be, but I guess I've worked with quite a few, and I've got some heroic stories, and they've inspired me, and I want to share that with you. First of all, I have no conflict of interest. However, I am very interested in conflict. We spoke about potential conflict between people in the team the other day, and I'm interested in preventing conflict and de-escalating conflict, but when conflict is inevitable, in winning that conflict. And the most challenging conflict is the conflict that happens within ourselves, against ourselves, and how we overcome that. We know to make things happen, we need to control our environment, the team, the patient, but above all, we have to control ourselves, and that's what this talk is about. Because there are times when we are faced with situations, with circumstances that require us to really dig deep into our cognitive and emotional reserves and really pull it out of the bag and do the right thing despite very difficult circumstances. First story. This is Ed Valentine. He's an ED critical care doctor in the UK. In addition to working for HEMS, he responds in his own time for free from his own home for the ambulance service when they call him out. He's called out in the middle of the night to a motorcyclist who's crashed down a country lane 50 kilometers from Ed's house. This is in a rural part of the country. There aren't many other resources. He gets there. This guy is really sick. He's smashed into a car and has been thrown 30 feet from his motorcycle. He's lying on his side. He's got an airway full of blood. He's got saturations of 85% on oxygen, a blood pressure of 65 on 48. He's tachycardic. He's having trouble breathing because of the blood in his airway, but he is conscious. He's got multiple upper limb fractures with bits of bone sticking out. He is big sick. He's got a penetrating wound to his neck. This is the actual patient presented with his permission. The wound is bubbling, suggesting a tracheal injury, but you can't actually see entry into the trachea. You just know that the airway has been breached. There's a lot of blood coming out of the wound. Ed's got a tough decision to make. There are resources on scene. There's an ambulance and a helicopter has just arrived, manned by paramedics that don't have advanced airway skills. The local hospital is still a long drive and has no trauma facilities. The trauma center will be a 20 or 30-minute flight away. But this patient is too sick to put in a vehicle and run. He will die before he gets to hospital. But this is a difficult airway. We can really run into problems trying to mess around on scene and delay scene times. What did Ed do? These are his words. I made the decision pretty much immediately that we needed to secure his airway. Leaving him with an unsecured airway really wasn't going to be an option. Things were only going to get worse. He made the decision immediately. Not treating him wasn't going to be an option. These are key phrases and thought processes. So he briefs the team, he gets his own equipment out, he draws up his drugs, he gets bilateral vascular access in. He sets up for RSI, but he does a double prep, prepares for a surgical airway. Going straight into the hole in the trachea is not an option. He considered that, but the wound was not obvious in the trachea. He gives a small dose of ketamine and a big dose of SMACC after pre-oxygenation. He pre-prepares a small tube as well as a standard-sized tube. He intubates over a bougie, passing the bougie really carefully with a bit of subglottic resistance and then feeds it through. The size 8 tube meets resistance below the cords. He pulls that out, he gets a smaller tube, puts it in, feels a bit of resistance, twists it gently, feeds it through. He then inserts it an extra 2 centimeters beyond where he would normally insert it because he wanted to get the cuff below the level of the wound in the trachea. Inflates the cuff, connects to end-tidal CO2, ventilates the patient. The SATs come up, it's got a good CO2 waveform. Gives a crystalloid bolus, gives tranexamic acid, splints the pelvis, splints the upper limb fractures, flies the patient to hospital. The patient has a complete transection of the trachea and the esophagus. He makes a full recovery, a full neurological recovery. So Ed's actions, in my mind, were heroic. Had it gone wrong, you can imagine how he might have been taken to the cleaners by critics who don't understand the mind of the resuscitationist and who don't understand pre-hospital critical care. Were Ed's actions heroic? He was doing this for free. There was no prospect of any kind of reward. He had kind of everything to lose and nothing to gain, apart from the well-being of his patient. He was doing the right thing according to the values that he subscribes to. Is that the mark of a hero? What is a hero? I think we need to talk to an expert. Who are the experts on heroes? 3-year-old boys. This is my son, Cal. We'll rerun that with sound, please. Can you make sure the sound's working? Ready to go? What kind of things does a hero do? Do they do the right thing or the wrong thing?
The right thing.
That's right. Why do they do the right thing?
Because they are superheroes. Yeah.
All right. What if the bad guy is really strong and has weapons? Is it a bit more difficult then to fight them?
Yeah.
All right. So if it's difficult, why do they do it?
Batman is brave and bold.
Because Batman's brave and bold. Okay. Does he give up or does he keep trying?
Keep trying.
Great, keeps trying.
What's give up mean?
Give up means you stop trying. You decide you can't do it. Just keep trying is the right thing to do, isn't it?
I keep trying.
Good. Are you a hero?
Yeah.
Good.
Cow.
Super cow. So that was helpful. But maybe we should look at some other authorities. It's hard to find consensus on what heroism is in the psychological literature, but a recent and helpful and largely agreed upon definition is this. Heroes do the right thing in difficult circumstances, often weathering personal risk to help others with no expectation of personal gain. They are guided by a strong moral compass and persist despite setbacks, often overcoming fear to achieve a goal, accepting the consequences of their actions. So they have a strong moral compass. They do the right thing. They help others in difficult circumstances. There's often personal risk and no personal gain. They overcome fear and persist despite setbacks. So I think Ed was a hero with this job. I think he does fulfill that definition. But was Ed born with heroic DNA? Or is this something that your average person can acquire? Can you learn to be a hero, and consequently, can you teach heroism? To answer that question, we need to look at the work of Professor Philip George Zimbardo, a fascinating career. Early on, he was the brains behind the Stanford prison experiment. Now, this is when they took a cohort of students and asked them to act in a scenario for days as prison guards, and another cohort of students to act as prisoners. And with time, those who were acting as guards became more and more abusive to the point where it was getting out of hand. The Milgram experiments took subjects and asked them to deliver electric shocks to actors with a pretend machine. And when guided to do so by someone who was posing as an authority figure, normal, nice people would increase the electric shock magnitude to the point where the dial said lethal, and they carried on doing it. This taught us that normal people can do evil things depending on the circumstances. And this has gone a long way to understanding other atrocities like the Abu Ghraib prison situation. And this is really well summarized in Zimbardo's book, The Lucifer Effect. But it's not all doom and gloom. There's an uplifting side to Zimbardo's more recent work. So in a study of over 4,000 Americans, it turns out that about 20% of responders to a survey had acted in a way that met the criteria, the predefined criteria for heroism. About 20% of people have been or regularly act as heroes. So perhaps we can teach it. And this led rise to the Heroic Imagination Project, led by Zimbardo. I'll put a link to this on my website. The idea of the Heroic Imagination Project is to try and inspire more and more people to act as heroes, to increase this 20%. Interestingly, in studies of disasters like earthquakes or skyscraper fires or airline crashes, about 3/4 of individuals become paralyzed by the overload of their sensory input and their reaction to it, and are unable to help themselves or to help others. About 5 to 10% just go nuts and exhibit destructive behavior. But up to 20% maintain situational awareness and maintain the ability to control their actions and their thought processes and their judgment, and can assist in their own and others' rescue. There's that 20% again. Another story. This is Roger Bloomer. He's a HEMS doctor. He was working for us in Sydney. He responded by road ambulance with his buddy, the paramedic Rod Wheatley, to a lady who'd collapsed. She was 31 years old, 38 weeks pregnant, had abdominal pain, collapsed in her own home. On their way to the job, Roger and Rod discussed the possible outcomes and what would be required of them. Roger said, if she arrests, I'm going to do a cesarean delivery, and I need you to manage the maternal ACLS. Rod said, fine, we'll do that. They get there shortly after the arrival of a road paramedic crew who'd started basic life support because the lady had just arrested and was going into asystole. Rod took over the ACLS, as agreed. Roger got out the scalpel, opened the skin and the uterus, took the baby out, who was apneic and floppy and bradycardic. Clamped the cord, stimulated the baby, delivered some initial ventilations. Started CPR, intubated the baby, got the heart rate up, got the sats up, delivered a pink baby to the neonatal unit. What was it about that job that was special? In my mind, it's they didn't have to do that. No one else does that stuff. It wasn't expected of them. Before Roger did the operation, in this lady's bedroom, he had to explain to her husband and the father of her unborn child what he was about to do and why he was doing it. He kept clear, he kept his focus. He was able to maintain this cognitive resilience and see through the procedure to the end point. We looked it up. It's the second one described in the literature. And to me, that was heroic. Why doesn't everyone act like this? I hear countless stories, and it saddens me. Countless stories from colleagues of all grades about how they stood by and saw a failure to act by the team when one of these life-saving interventions was indicated. Could be a hysterotomy, could be a thoracotomy, could just be a lateral canithotomy. But it's something life, limb, or sight-saving. And people come up with excuses, with self-delusion, with opportunities to opt out. And I want to understand why. And can we fix that? Can we inspire people not to fall into these traps? I even persuaded the president of the College of Emergency Medicine in the UK to co-author an editorial where we make arguments, clinical and ethical and practical and medico-legal arguments of why emergency physicians should be prepared to do these procedures even if they don't feel adequately trained, because it's the best bet for that patient. And I did this in the hope that if they weighed the arguments up in advance, they wouldn't spend time and cognitive resources weighing it up when the moment comes to decide. They will just act. But I think there are other factors that stop us from acting. Many of you will be aware of the Elaine Bromley case, a sad tale of a young mother who went in for a routine elective operation on her sinuses. She suffered a hypoxic brain injury and ultimately died because of a failure to secure her airway, despite 2 anaesthetists, an ENT surgeon, and at least 3 theatre nurses struggling to gain control for about 25 minutes of profound hypoxia. Nobody discussed surgical airway, despite the existence of algorithms, despite training. Nobody even discussed it. The closest they got to it was about 7 minutes in with sats of 40% on the monitor, when one of the theatre nurses said the tracheotomy tray is out and ready, but didn't push it any further. You can read the inquest report online. It's sobering reading. It's hard to understand why Dr. A and those with him persevered in trying to intubate the trachea. He would have resorted to a surgical access to the airway. That's what he said. Would have. He still does not know why he did not do so. Theatre staff, when interviewed, all seemed surprised that a surgical airway was not performed. They were surprised it wasn't performed, but they were there. They could have made it happen, but they didn't. Why? Why didn't they do it? There is this concept of the bystander effect, where there's a diffusion of responsibility amongst the team. And this is worse the more people there are. The more people in your group that appear comfortable with this bad situation, the less likely you are to step up and say, this is wrong, we need to act. This comes back to the social proof persuasion principle that I discussed the other day. You don't want to go against the consensus of the crowd. The bigger the crowd, the less likely you are to be that person who puts their hand up and stops it. So maybe that's one thing that contributes to our colleague saying, I didn't act. What else could be getting in the way? This is a personal story, but we need to bear in mind that all that's required for evil to prevail is for good men to do nothing. Don't wait for someone else to act. That's bad. Be the one who acts. So here's my story. Sorry, I forgot this. Joe Darby was the guy who was a military police officer, I think. He was in the army in Iraq, and he was the whistleblower on the Abu Ghraib atrocities. Enormous personal risk and safety risk by bringing that up and blowing the whistle on his colleagues. But this is what he said. It violated everything I personally believe in and all I've been taught about the rules of war. He was different from the other good people who stood by, who knew it was happening, but due to circumstances did not act. Think about how many good Germans there were during the Holocaust. Probably lots and lots. But they were not standing up and acting because they're normal and their circumstances dictated their actions. Okay, I used to work for a pediatric and neonatal retrieval service as a registrar, and my first ever job after an absurdly cursory introductory training period of a few hours was to go out and deal with a newborn, a term newborn, with respiratory distress, born in a private hospital with no neonatal intensive care and limited pediatric support. The pediatrician had gone home because the kid was really sick. Incidentally, what's the definition of an emergency to a pediatrician? It's when they have to put their handbag down to deal with it. Okay, so I get there. I should have told an orthopedic surgeon joke. You'd have gone, yeah! But we do like our pediatricians. Okay. So, I get there. This kid is really sick, really blue, really shocked. I have to anesthetize him, intubate him, get umbilical access to start vasoactive drugs. He's still really sick, really blue. He's got persistent pulmonary hypertension of the newborn. I've got to somehow arrange to get nitric oxide delivered to this hospital so we can set that up. I get some help from the boss in with that one. That sounds bad enough, but the kid's dad was a pediatrician who'd previously worked for this retrieval service, who stood there with his arms folded, looking totally pissed off, which is understandable. But to me, it was what Joe Lex referred to as the imposter syndrome. He can see right through me. He knows I don't know what I'm doing. The nurse then starts asking me questions about drug doses, and I almost lose it. I've got this snowstorm in my head. It's a white noise of negative thoughts. And I remember this so clearly. It's 11 years ago now. But so clearly, my own voice in another part of my brain says, you can do this. You have to do this. You have to do this for this family. You're the only one here that can fix this situation. You're going to do it. You're going to fix this. Concentrate, focus, listen to the nurse and think and forget everything else. And I managed to dig down deep somewhere and pull it out the bag. And the kid did fine. And the dad and I became friends. So what I'm talking about there is cognitive resilience. I subsequently learned years after this that what I was doing was called positive self-talk. This is used by high-performance athletes under extreme pressure. This is used by military teams that have to face immediate action against insurgents. It's mindfulness and metacognition when you're being aware of your own emotional responses and thought process and able to analyze them and control them. This is cognitive resilience. You can train this, and it's important too. This guy's Michael Wilson, a special casualty access team paramedic with the Sydney HEM service. Some of my best jobs have been with my friend Mick. He and I worked on Australia Day a couple of years ago. It was the most blisteringly good shift I've ever done. Several winch missions, some complex, sick, critical care. The thirstiest I've ever been in my whole life was working with Mick. On Christmas Eve, year before last, Mick goes to rescue some injured canyoners. and he's winching one of them up, strapped to the patient, and there's an accident, and the winch cable slams into a rock face, and Mick's pelvis takes the full impact of that collision. It briefly renders him unconscious, so he can't signal up to the helicopter. So they're waiting and waiting, but they conclude the safest thing to do, he's close to the ground, is to cut the winch cable. So they do that. He and the casualty fall to the floor. He regains consciousness. He manages to get the patient to a place of safety, to brief them, to give them some safety equipment and explain to them they're going to be okay, because help will be on its way. Mick then closes his eyes for the last time. I knew this would happen. Why was he able to do that? Why was he able to act like that, despite the fact that he was dying a hemorrhagic, hypovolemic death? It's because he didn't have to make a decision at that point. He knew who he was. He defined himself by a set of values. This is this moral compass that we mentioned before. I'm exercising cognitive resilience at the moment, can you tell? So his wife loses her beloved husband, and his gorgeous kids lose their father, and we lose a mate. But the world remembers a hero. That's what a hero is. Self-talk. Incidentally, I'm also exercising autonomic resilience because I'm dying for a piss. Okay, so let's bring it home. How do we become a hero? We have to know who we are. We have to know how to define ourselves, what we stand for, and more importantly, what we're not prepared to put up with. We're not going to stand by and watch certain things. And then we have to make ourselves ready. This is cognitive readiness. We can train our cognitive readiness with simulation. I've said it before. We have the most powerful 3D high-fidelity simulator in the known universe, in here. We can use it. We can rerun these scenarios, so we're able to make it happen. But we have to weigh up the pros and cons of this stuff before. We can't be talking ourselves out of it. We have to be prepared for all the outcomes and take responsibility for them. We have to look out for the opportunity and not miss it. Maintain situational awareness. Zimbardo calls this having a discontinuity detector. What's happening now doesn't fit in with what I find acceptable. I am now going to act. And we need to make that decision. We mustn't be paralyzed by indecision and the bystander effect and fear and the group paralysis and the social pressure. We have to be the ones that stand up and fix it. And then once we start, we have to see it through to the finish. We have to be able to keep going. We have to exercise cognitive resilience. And once again, we can train that through simulation. So I want to know if you're ready. I want to know if you've decided who you are and what you stand for. I want to know that you're prepared, that you're cognitively ready, that you're going to train and you're going to weigh up and not be paralyzed by indecision. You're going to weigh up the implications of your actions and take responsibility for the outcomes. I want to know that you're going to recognize the situation. Your spider sense is going to be on fire and you will act. And I want you to make the decision right now, not at the time. You have to make it now so that you are ready. And practice and train the cognitive resilience. Use those tools. They will get you through. Have a crystal clear image in your mind of where you want to be and get there, get the patient there. So I've hinted at it before, I believe, and I guess the objective, verifiable scientific data would support the fact that we only get one life. And this applies to all of our human brothers and sisters. And we owe it to them and we owe it to their families. And we owe it to ourselves so we don't live with regret forever, to pull it out of the bag when it counts. We need to be able to do this, and I want you to be able to do this. Because I am sure that you can. I believe you can. I know that I am looking at a room full of heroes. Thank you.